Hello, my name is Haley Eves, here with Maddie Engel and Kayla Lipsky. We are SRNAs at Arkansas State University, and today we'll be discussing prone CPR. The main objectives of this presentation are for the learner to identify initial actions during prone cardiopulmonary arrest, demonstrate accurate prone CPR hand placement, select appropriate prone defibrillator pad placement, and apply evidence-based prone compression parameters with monitoring strategies.
Cardiac arrest can occur in the prone position, especially in the OR during spine and neuro cases. This can also occur in the ICU where patients are prone due to having COVID and developing ARDS. From turning a patient from prone to supine takes several minutes and multiple team members. Since survival rates decrease by about 10% for every minute without CPR, these delays are critical. Therefore, current evidence supports initiating CPR in the prone position when immediate repositioning is not feasible.
So the AHA actually currently states that when the patient cannot be placed in the supine position, that it may be reasonable for rescuers to provide CPR with the patient in the prone position, given that there is an advanced airway in place. The reason that we are doing this education and doing this project is that while the AHA does recommend this, there isn't a lot of instruction on how to perform prone CPR. So when is this going to be appropriate? The arrest needs to be witnessed. There needs to be an advanced airway already in place, an ET tube. They need to be already mechanically ventilated. This is going to prevent any kind of airway collapse during CPR, and the AHA actually does specifically say this. So this is going to be appropriate for patients who are already positioned prone. Maybe it's a spinal case, or it's a patient in the ICU already prone for ARDS or any kind of respiratory distress. This is going to be in a case where supination is not immediately feasible. So if you can flip the patient supine just like that really quick, that's great, and we need to go ahead and do that. But this is whenever you don't have enough staff, not enough hands on deck, or there's just monitors, drapes, equipment in the way where you cannot immediately flip them supine. So we go ahead and start prone CPR until we can flip them. Some relative contraindications is going to be spinal injury, and this is talking about like a spinal trauma that comes in, an advanced airway isn't in place. This isn't going to be our controlled surgery setting. Active bleeding or inadequately trained staff.
At the time of arrest, the priority is to act quickly and do not delay care. First, confirm cardiac arrest and activate the code response team. Compressions should be started immediately in the prone position. At the same time, initiate ACLS protocols including monitoring, medications, and defibrillation as indicated. While resuscitation is ongoing, the team should assess whether it is safe and feasible to turn the patient supine, but CPR should never be delayed to reposition the patient.
So these next couple slides are going to talk about adequate hand placement during prone CPR. Our first is going to be midline over the thoracic spine. We're talking about the T7 to T10 levels, and you can see in this picture that that's what this person is doing. So you see the black line representing the inferior angle of the scapula. We're going to go 0 to 2 segments below that. So T7 to T10, some sources may say T7 to T9, but that is what we're aiming for here. The compression rate and depth is going to be 100 to 120, and the depth is going to be 2 to 2.4 inches. So this next hand placement option is going to focus on increasing compression depth and mainly lowering rescuer fatigue during prone CPR. So in this demonstration, this is a newer simulation study from 2024, and they found that straddling the bed and having both hands placed bilaterally over the scapula is going to increase compression depth and lower rescuer fatigue. So both are great options for you if you're doing prone CPR. Whatever one is more feasible is going to be the better option.
Counter pressure is an optimal technique that can improve compression effectiveness. It involves applying firm support at the sternum, creating a more rigid surface, and this allows for better transmission of the force to the heart and increasing intrathoracic pressure. This can be especially helpful on those softer OR tables. However, it is important that this does not delay the initiation of CPR. Defibrillation can be safely and effectively performed in the prone position. The preferred pad placement is anterior and posterior, but if that is not feasible, alternative positions such as mid-axillary to scapular or bilateral axillary placement can be used, as seen in the photos. The main priority is to deliver a shock when warranted without delaying CPR for repositioning. Current evidence also shows that the standard energy levels can also be used successfully in the prone patient.
To assess the efficacy of prone CPR, we rely on physiologic indicators. The two most reliable confirmations are end-tidal CO2 and the arterial waveform in the event an arterial line is already present. An end-tidal CO2 of at least 10 to 15 millimeters of mercury and a diastolic blood pressure of 25 or greater suggests adequate perfusion. A consistent arterial waveform alongside compressions is also a strong indicator of productive CPR methods. If these targets are not being met, compression techniques should be adjusted. While prone CPR can be effective, there are situations where transitioning to supine is necessary. This should be considered if hemodynamics remain poor despite optimized prone compressions, such as persistently low end-tidal CO2 or diastolic blood pressures, or if there is no return of spontaneous circulation after adequate cycles. If sufficient staff and conditions are favorable to safely turn the patient without significant interruption, transitioning to supine CPR is appropriate.
Prone CPR is an evidence-based, safe option when repositioning is not feasible. Proper technique and hand placement are essential for effective compressions. Defibrillation can also be performed without turning the patient when the pads are placed appropriately. Overall, prone CPR is a practical approach that should be incorporated into clinical awareness and training.
Hello, my name is Haley Eves with Arkansas State University, and this is my friend Andy. We're going to be doing a brief simulation on how to apply defibrillator pads and perform chest compressions on a pronated patient. To perform compressions on a pronated patient, place hands midline over the thoracic spine around T7 to T10, just below the scapula. This corresponds to the largest cross-section of the left ventricle. Deliver compressions at a rate of 100 to 120 per minute with a depth of 2 to 2.4 inches. Ensure the patient is on a firm surface. Additionally, you can place counter-pressure using a saline bag, a towel, or a fist. In this situation, we'll be using a rolled-up towel. Place it under the sternum to improve compression force. Defibrillation in the prone position is safe and effective. Place pads bilaterally under the axilla or on the left shoulder to the right axilla. In this position, bilaterally under the axilla, or on the left shoulder to right axilla. Deliver shocks using standard energy levels without delaying CPR. Utilize end-tidal CO2 and hemodynamics to assess compression quality. Prone CPR follows the same principles as supine CPR. Start immediately, minimize interruptions, and deliver high-quality compressions as according to the ACLS guidelines.
Thank you very much for watching our video, and we will leave the floor open for questions.
And these are our references.